Well, dear colleagues, again, it's a great pleasure to be here. And Lawrence, thank you very much for including me in the program. In the next 30 minutes or so, I will talk about the MRI of the elbow ligaments, tendons, and nerves. And before I start, I would like to say that in the institution where I work, we have 4 hand surgeons, upper extremity surgeons, and majority of the tendons in the elbow, forearm, hand, and wrist, we evaluate by ultrasound. Very rarely we do MRI for the tendons in the upper extremity, except for shoulder, depending on patient's age. Also, the nerves of the upper extremity, most of the time we evaluate by ultrasound. So this is the hospital where I work, and I don't have any disclosures. So we are going to talk about normal findings, traumatic and overuse injuries of the elbow ligaments, tendons, and nerves on MRI and MR arthrography. As you know, the examination needs to be performed on high-resolution MRI machines, typically 1.5 or 3 Tesla, in 3 imaging planes, and then sometimes, additional imaging planes are added as needed, like coronal oblique. We are applying T1 weighted, fluid sensitive sequences and gradient echo sequences of plain MRI, and for MR arthrography, T1 weighted with fat saturation, and add at least 1 fluid sensitive sequence with fat saturation to evaluate soft tissues, and 1 T1 sequence without fat saturation to evaluate the bony structures. The patient is usually in prone position with elbow in extension and forearm supination, that's Superman position. And this is sometimes uncomfortable, and in that situation, the patient is placed in supine position with the elbow and the arm on their side. We use dedicated coils for that, small field of view, and with joint effusions, intra-articular contrast injection may be omitted if we are considering doing MR arthrography. How we inject the elbow for MR arthrography, I like the lateral approach. Some of my colleagues like posterior approach, and we inject small amount of diluted gadolinium-based contrast, usually less than 8 milliliters. So now I'm going to talk about the ligaments of the elbow, and as you know, normal ligaments show low signal intensity on all pulse sequences. They may show increased signal intensity on short TE sequences due to a magic angle artifact. And partially torn ligaments show focal increased signal and irregularity, while complete tears present with discontinuity of the fibers, and there could be a fluid at the tear site. Now again, I'm not going to spend too much time on this. It is just to say that the chief stabilizer of the elbow against valgus stress is the medial ulnar collateral ligament with its 3 bundles, with the most important one being the anterior bundle. You can see over here how far this anterior bundle can extend across the proximal ulna. On the lateral side again, there are radial collateral ligament, lateral ulnar collateral ligament, which is a major stabilizer against varus stress, and posterolateral rotatory instability, annular ligament about the radial head, and variably present accessory collateral ligament. Now, when you inject the intra-articular contrast, you definitely see the ligaments better. And I'm showing over here the radial collateral and medial ulnar collateral ligaments on this image. And here you can see the lateral ulnar collateral ligament as a nice low signal intensity bundles. The common extensor and common flexor tendons are located superficial to the ligaments, and they show low signal intensity, as you can see over here. And you can see nicely here the distal aspect of the lateral ulnar collateral ligament. Also take in consideration that the proximal origin site of the anterior bundle of the medial ulnar collateral ligament may be a little bit more like fan-shaped and may have some increased signal intensity, which is normal finding. Now, I do like this coronal oblique plane, and we use it when we are doing MR arthrograms to show the lateral ulnar collateral ligament and anterior bundle of the medial collateral ligament. in kind of optimal plane. And you can see what we're doing over here. So this is the LUCL, and this is the medial ulnar collateral ligament. And we basically use this coronal oblique sequence with about 20 degrees of posterior angulation, and that allows us a nice evaluation of the LUCL. Now also, this over here, this void of cartilage is a normal finding in the elbow, in the olecranon fossa. The annular ligament extends along the radial head and attaches to the proximal ulna, as you can see here. Now here is an example of a full thickness tear of the medial ulnar collateral ligament, anterior bundle, on MR arthrography. And typically this ligament is most commonly torn in the central part, but also the distal and proximal tears do occur. And you can see over here a leak of the interarticular contrast to the full thickness ligamentous tear. You can nicely see the normal radial collateral ligament tear, and of course you need a fluid sensitive sequence to look the adjacence of tissues and for bone marrow edema. Also, please note here the synovial fringe, which is a normal finding, but if there is hypertrophy of this structure, that may be symptomatic. Here is another patient with full thickness acute tear of the anterior bundle of the MUCL. This bundle is ruptured at the central to distal aspect, and you also can see over here the associated contusion of the capitellum with bone marrow edema. The T sign on MR arthrography image is useful to evaluate for partial detachment of the distal aspect of the anterior band of the medial ulnar collateral ligament. Also, take in consideration that there are some variants, and this is not always firmly attached. There are sometimes some small sulci normally seen in this region. However, what we see over here is too much. And ancillary signs which can help is a bone marrow edema in the adjacent coronoid process. And this was a baseball pitcher with injury of the MUCL. Now here is an example when even despite MR arthrography, the partial thickness tear, partial detachment is poorly visualized, and this is consequence of chronic tear. This is an ossicle which you can see on the plain film on MRI, but the patient was taken to OR and this was fixed. This is an example how MR arthrography can help in evaluation of the partial thickness tears of the collateral ligaments of the elbow. You can see over here the contrast undercutting the ulnar attachment of the anterior bundle of the MUCL, which we were not able to see on the regular MR images. However, there was little bone marrow edema in the coronoid process. So, when we do MRI or MR arthrography of the elbow is really to evaluate pitcher's elbow in our clinical setting, and also look for valgus expression overload syndrome, which is a pitcher's elbow. Repetitive stress of pitching leads to excessive shear forces on the medial aspect of the olecranon tip and olecranon fossa, and lateral radiocapitellar compression, posterior extension overload, and medial tension at the MUCL. So pathologic biomechanics leads to chondrolysis, osteophyte formation at the posteromedial aspect of the humerus and olecranon, formation of the loose bodies, and the medial ulnar collateral ligament can become attenuated or thickened with repetitive strain. About 25% of these patients have associated cubital tunnel syndrome. They can also have associated common flexor tendon injury. Here is the 20-year-old baseball player who has valgus extension overload syndrome. I will show more images on the next slide, but he is status post MUCL repair. You can see the ligament attenuated in this region. So what you can see over here, we are at the posterior aspect of the elbow. You can see large osteophytes arising from the olecranon, and about the ulnar-trochlear articulation related to shear stress or valgus extension overload syndrome. The patient usually presents with posteromedial elbow pain with full extension of elbow, typically in the deceleration phase of pitching or sometimes during acceleration phase. So what is the treatment for this? Initially conservative, and if that fails, surgical. Surgical treatment comprises resection of the posteromedial osteophytes, removal of loose bodies, and debridement of chondromalacia. Relative contraindication for debridement of osteophytes is MUCL insufficiency. Another patient with valgus extension overload syndrome, this is a 23-year-old pitcher with elbow pain. He underwent the MUCL reconstruction 18 months prior to this MRI study and presented with, and also he had a ulnar nerve transposition, and he presented with pain. What you can see over here, there is a very thick repaired ligament, and this is difficult to evaluate postoperatively because you're using kind of like a double bundle there and looks thicker than a normal ligament. So this was intact. However, there was bone marrow edema in the proximal ulna as well as posterior osteophytes consistent with valgus extension overload syndrome. In addition to that, the ulnar nerve, transposed ulnar nerve, had a lot of scarring about. So it was very difficult to discern it from the scar tissue. And now regarding the lateral elbow ligament injuries. This is again, as I mentioned, most commonly associated with subluxation or dislocations of the elbow. And this is at least stage 3B, posterolateral rotatory instability, because all ligaments are torn, including the radial collateral, lateral ulnar collateral, and both bundles, anterior posterior medial ulnar collateral ligament. What I'm saying at least 3B, because that makes it 3B, but also there's some edema about the common extensor and flexor tendons, which may be injured, so that will make it as a 3C. And you can also note over here, there is a strain with edema in the brachialis muscle. So, not ligaments, but synovial fold or plique could be symptomatic if thickened, and in throwing athletes, and also the fibrotic synovial fringe at the lateral aspect of the elbow if hypertrophy could be sometimes symptomatic. So now I'm going to talk about the MRI of the elbow tendons. Normal tendons, as you know, show low signal intensity and again may have increased signal on short T sequences due to magic angle artifact. The spectrum of tendon pathologies includes tendinopathy or tendinosis with tendon thickening, heterogeneity, and intermediate increased signal intensity. Bicipito-radial bursitis because there is no synovial sheet, partial or full thickness tearing, and again with full thickness tear, there is discontinuity of the ligamentous fibers, and with acute tears you can see fluid at the tear site. So the lateral epicondylosis is usually diagnosed clinically. Very rarely we do MRI for this. Peak age is 40 to 60 years. The etiology is refractive varus stress on elbow, and we see increased signal on T1 and fluid sensitive sequences with interstitial tearing, and there could be associated injuries of the lateral collateral ligamentous complex. It could be bone marrow edema in the lateral epicondyle. Here is the patient who indeed has both lateral epicondylitis and injury of the humeral origin site of the radial collateral ligament and lateral collateral and lateral ulnar collateral ligament, as you can see over here. And this is the distal aspect of the radial collateral ligament. And here is that normal appearance of the proximal anterior bundle of the medial ulnar collateral ligament. Sometimes has an increased signal there. Another patient, this one has a history of lateral epicondylosis, but sustained acute trauma. You can see more pronounced partial thickness tearing at the common extensor tendon origin side. And again, extensor carpi radialis brevis is the most commonly injured. So the medial epicondylitis, again, something which we most of the time diagnose clinically. Same thing can apply to the medial side with tendon thickening, partial thickness tearing, heterogeneity, increased signal, and also could be injury of the associated medial ligamentous structures. And also ulnar nerve could be affected. Here is the patient with medial epicondylosis and partial thickness tearing at the common flexor tendon origin site. Now, when evaluating the distal biceps tendon, we frequently add this so-called FABS position, which is flex abducted supinated view, which enables stretching of the distal biceps tendon and sometimes helps in evaluation of the insertional partial thickness tears. We already mentioned this, the biceps tendon has two separate origins proximally and could have a single distal attachment at the radial tuberosity or bifid attachment of each tendon separately, and the lacertus fibrosus extends over the pronator flexor mass, and that's a fibrous aponeurosis. Here we are showing normal distal biceps tendon and the lacertus fibrosus, and in the vicinity is the brachialis tendon. Again, normal biceps tendon, normal triceps tendon, normal lacertus fibrosus, and this is so-called clinical hook sign when they are evaluating for biceps tendon injury. And here is the bifid distal biceps tendon, normal one, and here is the lacertus fibrosus. Again, short head attaches more distal when compared to the long head. So biceps tendon injuries, again, are less common in the distal than the proximal biceps, and the usual mechanism is eccentric loading, and this can occur with sports, and in our practice most commonly people with weightlifting or lifting something at work, heavy. This is more common in men, and with acute tears you can have a lot of blood at the tear site, and quite a bit of retraction over here is to the bilateral tendinous junction. In this situation with so much retraction, the lacertus fibrosus has to be ruptured. Here is someone with distal biceps tendon avulsion, and you can see over here irregularity of the lacertus fibrosus and significant retraction of the biceps tendon into the proximal arm, and the people develop these Popeye arm signs. Here is high-grade partial thickness tear, but still some fibers were attaching to the radial tuberosity. And here is someone which this was several years ago, and I thought it's going to be a full thickness tear. However, a patient had preserved supination, and he came to this exam, I think, a couple hours after golfing injury. This was a partial thickness tear, was treated conservatively and healed nicely. Here is the isolated tear to one of the heads. This is the short head, which is torn, and long head is just like a strained and still attached to the radial tuberosity. And here is someone with intact lacertus fibrosus, and retraction of the tendon is smaller, than less than when compared with, torn lacertus fibrosus, and that basically needs to be notified in MRI report. Again, a patient with bicipital radial bursitis, which can mimic soft tissue mass in the antecubital fossa. Triceps tendon tears, rare. Again, more commonly injured is like a conjoint tendon on the lateral head and long head, and frequently I have seen at least, and it is shown that the muscular attachment site could be partially spared. Over here is a patient with avulsed olecranon antizophyte, and you can see over here on MRI images retracted tendon. However, I think we always need the plain films because, small bone fragments you can easily miss on MRI. full thickness tear of the triceps tendon. What you can see is with high-grade injury, there will be increased signal without tendon disruption, but with full thickness tear, you will see disruption of the tendon fibers. And chronic repetitive overuse results in tendon thickening with or without associated signal abnormality. Here is an example of that when you have a few fibers preserved at the medial aspect, and that is that kind of more like a medial head or muscular attachment, and the other portion of the triceps tendon is torn. Now, lastly, I will talk about the nerves about the elbow. Again, we most of the time evaluate them with ultrasound in our practice. So what is unique about the nerves about the elbow? They are relatively superficial, especially the ulnar nerve. They pass through narrow fibromuscular or fibroosseous tunnels where they can be compressed, causing entrapment neuropathy. And MRI demonstrates changes in caliber or signal intensity of the affected nerve. May demonstrate masked lesions or anatomic variants compressing the nerve, and denervation changes which in early phase are characterized by edema and enhancement, and later on by atrophy. So, not to repeat where the ulnar nerve is sitting in the cubital tunnel, but this is where we're looking for the sites of the compression. And here is an example of cubital tunnel syndrome by MRI. This is the coronal image. What you can see over here, indicated by the red arrow, is flattening of the nerve within the cubital tunnel, and the nerve is thicker, proximal and distal to the cubital tunnel. Basically, MRI reveals focal diffuse ulnar nerve thickening with high signal intensity on fluid-sensitive sequences. Patients present with pain and paresthesia and sensory loss in the 4th and 5th digits and hand weakness. There are different sites again for ulnar nerve compression, as we already mentioned in the ultrasound lecture, just listed over here, and most of the time that's in the cubital tunnel. And unconeus epitrochlearis is an anatomic variant which can compress the ulnar nerve in the cubital tunnel, is replacing the roof of the cubital tunnel, and you can see over here this muscle, and underneath of the muscle you can see increased signal intensity in the ulnar nerve, and you look on the sagittal image, you can see the flattening of the nerve in the cubital tunnel underneath of this muscle, accessory muscle, and more thickening of the nerve proximal to the compression site, so giving, like some people say, cobra head appearance. The ulnar neuropathy or cubital tunnel syndrome is treated with transposition, which may be subcutaneous or submuscular. To my knowledge, subcutaneous is more common. I have only seen a couple times the submuscular transposition, and how that looks like. The ulnar nerve is displaced anteriorly from the cubital tunnel. The medial nerve compression, again, occurs, called Pronator syndrome, at the ligamentum of straters between two heads of pronator teres, biceps aponeurosis, flexor digitorum superficialis aponeurotic arch, and most frequently is due to muscle hypertrophy. So, Pronator syndrome is associated with pain, numbness, and paresthesia in the radial 3.5 digits. While anterior interosseous nerve syndrome or Killenevin syndrome is associated with weakness of the flexor pollicis longus, flexor digitorum profundus tendons to the 2nd and 3rd digits, and pronator quadratus. The anterior interosseous nerve arises from the in the proximal forearm from the median nerve. Here is the patient with pronator syndrome with edema in the pronator muscle, and the most common site of medial nerve compression is a fibrous band between deep and superficial heads of the pronator teres. Denervation changes of innervated muscle can be seen on MRI with high signal intensity on fluid-sensitive sequences, as you can see here, and again, fatty infiltration in the chronic stages. Here is a very interesting patient. We did both upper extremity MRIs on this patient who had Charcot-Marie tooth, and he had several compression neuropathies which were treated, including the Pronator syndrome and carpal tunnel syndrome. You can see over here is a huge medial nerve proximally to pronator musculature and relatively flattened in that region, and this was surgically decompressed. And the radial nerve. In the elbow, the radial nerve is located between the brachioradialis and brachialis muscle in the antecubital fossa and runs through the radial tunnel, which starts at the level of the capitellum and terminates at the lower border of the supinator. Again, arcade of Frosch is fibrous band along the superior border of the supinator muscle, seen about 30 to 50% of population. And thank you to University of Michigan for this image. This is from literature from their people. So the most common sites of compression again are the arcade of Frosch and within the supinator muscle between the two heads more distally. And what you can see on the images with supinator syndrome would be edema or atrophy in the supinator musculature and proximal extensor musculature. So, Waterman syndrome is related to the superficial radial nerve compression in patients presents with pain in the distal forearm and paresthesia in the hand. But radial tunnel syndrome can be mistaken clinically for lateral epicondylitis because the patients present with proximal posterior interosseous nerve entrapment and back pain over the lateral elbow and forearm. And we already spoke about the supinator syndrome. Here is someone with a supinator syndrome. What you can see over here is enhancement, minimal edema, and marked atrophy of the supinator muscle. And there is really nothing much more that I can see there except for prominent vessels about the supinator muscle. That was it about the nerves, and as you can see, MRI is powerful imaging modality, evaluation of several traumatic and non-traumatic pathologic conditions of the elbow ligaments, tendons, and nerves. And MR arthrography improves diagnostic accuracy in evaluation of the elbow ligament tears. However, I have to admit that less and less we are doing arthrography since MRI is getting better and better, and ultrasound also, especially with dynamic imaging, is better and better in evaluation of the ligamentous injuries. And I don't know what Dr. Morag and Newman's what do they think about this, but I think ultrasound is picking up, and with dynamic imaging we do more and more. References, and Toda again.